Olá, boa noite. Nós já vamos começar mais alguns minutinhos e logo as duas apresentações e discussão vão estar disponíveis, tá, para a gente ir seguindo. A gente já agradece a presença de todos.
Boa noite, pessoal. Boa noite quem está de casa. Peço desculpas porque o aviso ficou, como se iniciar às 7, mas às 7 começa o corte, às 7h30 a gente começa o evento. Então, acho que a gente está relativamente pontual, 7h28, agora está adiantado. Então, eu vou falar inglês, que a gente tem uma palestrante fora, o Diego vai apresentar em inglês também. Então, espero que vocês aproveitem. So, good evening. My name is Alessandro Pasqualotto. I'm in charge of the Infectious Disease Society of Rio Grande do Sul. And it's my pleasure here to be presenting this meeting that we're going to have two very key opinion leaders in the fields. First, Diego Falci from Thuy University and Hospital de Clínica de Porto Alegre will talk about cryptococcosis. And we will have the pleasure to have Thuy from Vietnam. Thuy is a very well-known person in the fungal world. She's a world leader in mycosis, and a fungal infection that is very relevant to Southeast Asia. And she's now a professor at the Duke University. Very good to have you with us, Thuy. Many thanks for joining us. And Thuy will talk about histoplasmosis, which is also, together with crypto, a major issue for HIV infected patients. So without any further ado, I think I'm going to invite my friend Diego to start talking. I have asked the speakers to talk for about 20-25 minutes, so we'll have time for discussions later on. And also, I'd like to thank the sponsor, Knife Therapeutics, for helping us organizing this meeting, and Cesar, who is here, who is also helped a lot to create all the systems for you to be able to see the talks from home. Diego, thanks.
Thank you, Alessandro. First of all, good evening, everyone. It's a pleasure to be part of this event. And I'd like to thank for the invitation. I'd like to thank especially to Dr. Thuy for being here with us. It is an historical event for us. We're very proud to be that. I would present here my lecture poses, and I will explore the guidelines showing the accumulating knowledge on this subject, and also the challenges that we still have to tackle this disease. As we all know, cryptococcal meningitis is a very highly lethal disease. So we have mortality rates above 40%, up to 80% in low and middle income countries. This represents 15 to 20% of all HIV-related deaths, huge numbers here. And we have a lower mortality in high-income countries. We can say that where the implementation of all the science that we're going to discuss today is successful, we can lower the mortality of cryptococcosis. And apart from patients that die, we still have long-term impairment, sensorial, neurologic impairment for these survivors. So the impact is huge. And we can say globally that the burden of cryptococcosis is very high. But we can say also that at the same time, this impact is quite disproportional between countries, between regions. We have the African region, as you can see here, with a huge impact of cryptococcosis. We have almost 200,000 deaths per year, which is a large number. And as I said, it's disproportional between countries, concentrated in Africa, and afterwards Asia, and afterwards Latin America. And we do have new technologies that change, that actually they are already changing this scenario, but we still need guidance, we still need recommendations, we still need implementation to better utilize these new technologies. In this lecture, we will explore 4 guidelines. I separated 2 guidelines that stated mainly for low and middle income countries, such as the South African guideline and the WHO guideline. But we have 2 guidelines that stated one global guideline from the ECRM and other guideline from the NIH designated for the US. And the first topic is prevention of cryptococcal disease. In this excellent review, we can see that we have many points for intervention since patients with cryptococcal antigenemia, asymptomatic, and the other extreme, patients with clinical meningitis. So we have identified in crypto the natural history of the disease, and therefore we can see many points for intervention that could lower the mortality of cryptococcal disease. And to prevent cryptococcal disease, one recommendation that is very important is to screen patients. So you have patients with HIV disease. In the WHO, they recommend for all patients with CD4 under 100 cells per liter, you have to screen them with cryptococcal antigen, and you have to give them preemptive therapy. And patients that perform a lumbar puncture, if they have a positive test, they must undergo a lumbar puncture. If they have a positive test, they will be treated for clinical, for instance. But if they do not have a positive test in CSF, they will go preemptive therapy. The WHO recommends also that you must implement primary prophylaxis, because this guideline is aimed for regions that have a high incidence. So you must implement primary prophylaxis. Do not have the capacity to screen these patients. The South African guidelines uses the genetic screening strategy with this consensus, but they recommend the screening of patients with CD4 counts under 200 cells per liter, so it's a higher cutoff. So that's different. But the rest of the screening strategy is the same. You undergo a lumbar puncture. If the CSF is positive, you treat with ample, but you implement preventive therapy in the case of negative CSF. The NIH offers a different strategy. They use different cutoffs, lower cutoffs. They recommend for under 100 cells per milliliter, but they particularly recommended for CD4 counts under 50 cells per milliliter. But the rest is the same. You must do a lumbar puncture in these patients, and they do not recommend primary prophylaxis. Even for the US, you do not have high incidence. An important thing about the use of serum testing is the prediction of disseminated disease. So when you have a serum testing, an LFA testing over 1/160, you can say that disseminated disease is highly probable. But if you have serum testing with LFA over 1/640, you must presume disseminated disease, including CNS involvement. So these patients must be treated as meningitis if they have this titer. And if you still use the old technology, if you still use latex agglutination, you must convert the titers from latex to LFA in order to categorize this patient. You must multiply with the latex titer by 4, and then you can compare it and presume or not the existence of CNS disease. About treatment, the guidelines have different recommendations because of difference in the context that they are able to, or about drug availability that are different from countries as well. A consensus between the guidelines is the strategy that is consolidated, which is induction, consolidation, and maintenance. So you do induction with a highly fungicidal antifungal, and then consolidation with high doses of other antifungal, and then you have maintenance to prevent relapses. I will give a special highlight of a study that changed the landscape of the treatment of cryptococcal meningitis, which is the ambition trial. The ambition trial compared single dose of liposomal amphotericin B plus cytosine plus fluconazole to the induction, compared to the, at that time, the recommended regimen by the WHO, which was amphotericin deoxycholate plus flucytosine per 1 week, and then the other week of induction high dose of fluconazole. And this study found that the single dose arm was non-inferior in terms of efficacy of compared to the WHO recommended regimen. And another important finding here is that the single dose regimen had fewer adverse events than the comparator, which is very important. Overall, we can say that this regimen offers significant benefits, such as economic benefits, practical benefits in terms of implementation, and also reduced toxicity and potential shorter hospital stays. So you have many advantages, particularly in low and middle incomes when you have difficulties to implementation of cryptococcal treatment. But authors have questioned this. They say that results of the ambition trial would not be directly extrapolated to different contexts, to high-income countries, for instance. But why not? I will give 4 arguments in the favor of using the ambition results to high-income countries, to other contexts, low, middle-income countries. We have a highly fungicidal regimen. So if you measure the EFA, which is an objective measure of fungicidal effect of the single dose, and you compare to other studies using Amazon, you can say that the single dose regimen is at least as fungicidal as other regimens using Amazon. So fungicidal effect will not differ from one context to another. Another argument important is fewer side effects, which is also reproducible in other contexts, such as high-income countries. When you talk about acceptability, you probably will have good acceptability by the patient or by the provider in high-income countries as well. But you have single dose, we have more practical regimen. And at last, you have cost, which is very important also in the context of high-income countries. We still have huge challenges in terms of providers, in terms of cost to the patient. So you have 4 important arguments to, yes, extrapolate the results from the ambition trial to other contexts, just like high-income countries. And why not like Brazil, which is a middle-income country? The WHO, after this study, rapidly incorporated the results to their guidelines. So we now have the recommended regimen by the WHO. We now have the single dose regimen as the preferred regimen, combined with flucytosine, combined with fluconazole in the induction phase of the treatment of cryptococcal meningitis. When we go to the other guidelines, when you go, for instance, for the ECMM guideline, the ECMM guideline gives 2 recommendations, different recommendations in the same guideline. They separated high-income countries with low-income countries, low and middle-income countries, and for the high-income countries, they still recommend the conventional therapy of Amazon during 14 days associated with flucytosine. And for the low-income countries, they already recommend the single-dose regimen, just like the initial trial. When you go to the National Institutes of Health, they are aimed for the US, before, which is a high-income setting. They are very conservative, and they recommend 2 weeks of amphotericin B, preferably Amazon, plus flucytosine. They also recommend other things which are not available in low and middle-income countries, such as PDM of flucytosine, for instance. And they recommend a new fungal culture 14 days in order to decide the patient advances. If they are stable, the patient advances to the consolidation phase. But if they are unstable, they keep on Amazon cycling for more time. And in the stable ones, you use the result of the fungal culture to manage the doses of fluconazole. If the fungal culture is still positive, you must increase the dose of fluconazole in the consolidation phase of the treatment. When we go to the consolidation phase, there's not much difference between the guidelines. They all recommend fluconazole. The only difference is the guideline of the NIH, the ACMM, which recommends in some settings the doses of 400 milligrams of fluconazole, but the other guidelines all recommend 800 milligrams of fluconazole during the consolidation phase. For maintenance, which is the third phase of the treatment, you should use fluconazole after 10 weeks of induction plus consolidation, and you should keep it for at least 1 year. The interruption, you have a slight difference because the cutoff used by the high-income guidelines, which is the NIH, they use you must have a CD4 count over 100 cells per milliliter. But the South African guideline and the WHO guideline, they recommend the interruption of fluconazole if you have viral load undetectable plus a CD4 count over 200 per milliliter. Another good discussion that we can have with the audience is the start of antiretroviral therapy. In general, we recommend a range 4 to 6 weeks, which is a large range. And you can start closer to 4 or closer to 6. It depends. And it is indeed a case-by-case decision. If it's possible, and if you have a negative CSF future, you could start earlier. You must not immediately start because it increases mortality. But if you have a more stable patient with a CSF negative, you could start earlier, closer to 4 weeks. But in other cases, you must wait a little more and start closer to 6 weeks. If you have a patient that you have started ART and you got a TMS as a cryptococcal meningitis diagnosis very early in the start of the ART, you could interrupt. You should consider the interruption of ART if you have a very early diagnosis after the ART start of cryptococcal meningitis. The South African guideline has 2 things that I think it's important for the audience. They almost are certain that you should start earlier, closer to 4 weeks, exactly at 4 weeks after the TM diagnosis, because they thought that the benefits outweighs the risk in this case. So you should start ART earlier, 4 weeks. And they also recommend, speaking of other entity, which is symptomatic cryptococcal antigenemia, these are patients that could start ART immediately. That's important to know, because if you have only antigenemia, you could start ART. And if by any cause you could not perform a lumbar puncture, you should start ART at 2 weeks. So that's important in the management of patients with cryptococcal antigenemia, which are asymptomatic. Another important recommendation from the guideline is that you should be aggressive in the control of intracranial pressure. You should measure it, the baseline when you get the diagnosis, and you should manage the symptomatic elevations of intracranial pressure. That's very important. You should perform, if needed, daily therapeutic therapies. So that's very important. That's a challenge for the infectious disease physician. And a huge challenge is that when you cannot control with therapeutic therapies, a huge challenge is to call the neurosurgeon and to have him to see the patient. That's a huge challenge because you know that in these cases you probably need more interventions such as shunts such as lumbar drainage or ventriculostomy. You need those things to further control the intracranial pressure. And you should not use, for the control of intracranial pressure, medications like corticosteroids, which are not routinely prescribed. And last but not least, I will talk a little bit about toxicity of the treatment. We know that amphotericin B particularly, but cytosine as well, are toxic drugs. These drugs have important side effects that must be monitored. And in most cases, you must keep the patient hospitalized to prevent these complications. And in these patients, you can prevent the toxicity of ampho, for instance. You can prevent using aggressive hydration. So you must give patients potassium, magnesium, and hydrated these patients. Important. And you must monitor the toxicity with blood cell counts, with monitoring of electrolytes, potassium, magnesium, creatinine. Obviously, this is very important to know that along the treatment, if the patient will develop some toxicity associated to amphotericin B or cytosine. And my message in this slide is very simple because it's something that is often underdiagnosed, which is anemia. We do not give the proper attention to this adverse event. Do not underestimate anemia. It has a clinical impact. It will impact in your outcome. So you must transfuse if you have patients with grade 4 anemia, with symptomatic anemia, you must give them blood transfusions. That's very important. Well, I have talked a lot about technologies, about strategies, but we still have a lot to do. In crypto, we can say that these technologies, such as amphotericin B, particularly single dose, cytosine, and the NFA testing, they have an important impact on the health of people living with HIV in the management of cryptococcal meningitis. But we still have a lot to do in the implementation of these things. We must give access to the people who need, to the people who do not have proper care for cryptococcal meningitis. And furthermore, we must learn what we have learned with crypto. We must learn with other fungal diseases, such as plasmodium, that Dr. Thuy will talk later. We must learn the same thing and implement the technologies that would change the landscape, the outcome of patients with fungal disease. And I'll be happy to take some questions afterwards. Thank you for your attention.
We have questions. I would like to invite Dr. Thuy to join us to give her talk on osmosis. Many thanks.
Thank you very much, Dr. Pasqualotto and Dr. Falci for the invitation. My first time in Brazil, and I've been very impressed. I had no idea what to expect in Brazil. I was in Sao Paulo just the last few days, and now here came yesterday morning. Well, this morning. I came this morning at 3:30 a.m. So you can see I'm a little bit dazed, but delighted to be here. So happy that you have this forum to discuss. And my task today is to talk with you about histoplasmosis and my experience treating histo, think about diagnostic and treatment. So the talk today will really focus on what do we have in terms of diagnosis and treatment and where we go and thinking about potential future treatment and diagnosis. Where are the gaps? And if you are a young clinician want to study histo, what area you may want to focus on? How about that as a talk? Okay. All right. So waiting for the talk to come up. Okay. Just a little bit about myself. My background, I'm a physician scientist, infectious disease clinician from Vietnam. I did all my training in the US, and I spent, after infectious disease fellowship, 10 years in Vietnam, building a research program around taloromycosis, which is a histoplasmosis of Southeast Asia. So taloromycosis, caused by one of the endemic mycosis, one of the 7 endemic mycosis of medical importance in the world. And so I built my research program around taloromycosis. There's so many similarities between taloromycosis and histoplasmosis. And so I'm very excited to work with Brazilian scientists here to try and bring some of the things that we learned from taloromycosis applying to histoplasmosis. Some of the things we learned from cryptococcosis to histoplasmosis. So that's sort of what the talk today will be. Okay, so first, histoplasmosis was discovered by Samuel Darling in 1906. And he was an American pathologist who was sent to the Panama, basically to build the canal. And he was working with William Gorgas to fight malaria and yellow fever. And then he basically is a clinician supposed to help them, help William Gorgas with it. And then he found patients who developed these symptoms of fever, cachexia, splenomegaly, and the autopsy of the lungs and liver and spleen show these granuloma. And there's basically organisms that look like protozoa in the liver and spleen in the autopsy. And you look at it under the microscope, and he named it Histoplasma capsulatum. And that's because they invade the histiocyte, which is the macrophage, and he thought it enveloped by the capsule. But actually, as we look at it in the next slide, it's an artificial, let me see. Beautiful. It's an artificial, you may not see it very well, but there's an artificial factor. It's not a capsule. Only crypto has a capsule, very thick. And that's how you can tell the difference. But histo does not. But it carried the name capsulatum because of that description. And so histo is really interesting. It's in the soil. It's beautiful in the mold form, very characteristic. It's beautiful circle with spike. And in the yeast form, in the host, it's this budding yeast. That budding yeast will be engulfed by the macrophage. We'll talk about pathogenesis in a little bit. But in the culture, you can see very classic picture in the mold form. You cannot miss this. It's very classic. You can actually diagnose in the blood smear of patient with disseminated disease. You can look carefully under the microscope and identify histo in this macrophage cell here. This is a skin smear. As you can see, this is a big macrophage that is kind of busted with tons of yeast in there. it's about 3 to 5 micron. And if you look at this, you said yeast, but it does not differentiate that from Talomyces monefii, which I work on, or some Canada, or some others. By looking at it, it's difficult to say, but if you are looking in Brazil, in Latin America, that's history to prove it otherwise. In terms of geographic distribution, it's very hyper-endemic in the river basin, in the Mississippi River Basin of the United States, and in Central and Latin America. And so these are hyper-endemic regions. We know that it's also endemic in other tropical and more temperate weather around the world. Actually, also in Southeast Asia, and we'll talk about that in a little bit, in southern China, along the Yangtze River, and in Thailand particularly. In Africa, we have a different strain or clade of histoplasma called Duboisii, mostly in Western Africa. But now the map expanded a little bit because there may be underdiagnosed, because we don't do any culture, this fungal culture in Africa, and there's not antigen tests available. And so, but there's some evidence that it's expanded beyond Western Africa as well. So there has been now 11 geographically distinct clades of histoplasma. So not just capsulatum, there's 11 other clades that are geographically distinct. So what is the ecology and reservoir of histone? We know already that there's Duboisii in Africa, and we'll talk about clinical manifestation in a little bit, but the reservoir is in the soil, particular soil that is enriched with bat or bird excreta. So they're in the feet. They're not, histo is not carried in a bat or bird, but in the soil that is contaminated with their feces. It's seemed to have a very favorable environment. And so the risk factors for exposure include soil work, so people who are in agriculture, and in construction site, demolition, in places where these birds and bats form houses, people who go to these bat caves, spelunking we call it, chicken farm. Actually, there's laboratory infection cases that has been reported. We have to be very careful. Looking in the lab, preferably when you manipulate the mold form, should have biosafety at least 2.5 facility. So there's several outbreaks of histoplasma. So we know by going to, there's Cave Explorer from the US and a bunch of students who go to Costa Rica to build things. They go to the cave, and people who did home construction develop an outbreak. There's about 20 kids who developed histoplasmosis, and of those, 6 of them was hospitalized in the United States, in Ecuador and Peru. So we know outbreaks happen. So not just, I think for healthy people, it's the inoculum. So if you're exposed with high inoculum, the risk of developing disease is much higher than us walking around with just a few inoculum. The pathogenesis, I just want to go through very quickly. So inhaling this spore in the lung and basically in the alveolar macrophage, what happened is that your alveolar macrophage engulf the spore, and essentially what it does is it just stay there. You're supposed to have reactive oxygen species and other things that kill off foreign particles. That's what macrophage does. This is a very important part of the innate immune response. Your macrophage is supposed to get rid of the pathogen, but in a lot of patients, they don't. Histone, in addition to being engulfed by macrophages, is also engulfed by the dendritic cell. These are professional antigen-presenting cells. When it engulfs into these, it basically expresses the antigen on the outside that get recognized by your T cell when your T cell recognize these peptide of histone, it essentially induces Th1 response. And what Th1 does, produce interferon gamma, and interferon gamma then activate this macrophage to try and kill histoplasma. So in normal people, interferon gamma released from T cell will help the macrophage to fight the infection and you form granuloma. So you and I probably been exposed to histone, and we have tiny granuloma containing histone in our lung without any problem until our immune system is suppressed and that this mechanism of T cell control of infection is impaired by HIV, for example, or people who undergo chemotherapy or any sort of Th1 suppression, then you can develop reactivation of disease. The host driver of histoplasmosis is very similar to other invasive fungal infections, and that includes uncontrolled HIV, yes, and immunosuppression, people with chronic diseases. Now we know that people with chronic disease can develop histoplasmosis, for example, diabetes, people with COPD, obstructive lung disease, they can develop chronic histone in the lung, and people who are basically in critical care units, they can reactivate disease. Other host factors include deforestation. We talked about human construction, human encroachment to the environment. We talked about spelunking, and we talked about travel. And so how are we doing in terms of Latin America? Where are we in terms of HIV control? Latin America is actually behind in terms of UNAIDS 95 goal. And so look at Latin America. You still, in the last year, this is data in 2022, very recent, published in 2023, you still have 8% increase in new incidents of HIV infection and 32% decrease in AIDS death, but the trend is not going down as you expect with increase of antiretroviral therapy. You still have 2.2 million people living with HIV, and of those people, you have still about 30,000 deaths per year. 30,000 deaths per year in Latin America. And how are you doing in terms of meeting this criteria? Supposed to be close to 95 by 2025. Look at where you are. 85% know their HIV status, 72% are on treatment, and only 66% are biologically suppressed. So there's still a lot of work to be done. In terms of disease spectrum of histone, there's an acute form of infection. So in healthy people, 90% of people are asymptomatic. Acute febrile illness happens in about 10% of people. And of those, they can have headache, pulmonary symptom, they can have pancytopenia, so their white cell, red cells, platelet can reduce. These are cell limited, over about 3 weeks. And this form of infection right now, we don't even look for. So a lot of people come in with community-acquired pneumonia or upper respiratory infection. We don't even think about histone. Luckily, most of us, it's cell limited, so most of us is fine. But some people develop chronic lung disease, and pretty bad chronic lung disease, and it's unclear. Obviously, people who have obstructive lung disease or structural lung disease, they will develop fibrotic cavitary disease, like in this picture. Some people develop mediastinitis, so inflammation of the lining of the heart, and some infected endocarditis as well. Lots of upper and lower respiratory tract. So histone love your mucosa. Lots of oral ulcers and upper respiratory infection, as you can see here. And this happened in healthy as well as non-HIV immunocompromised populations. So this is the chronic pulmonary upper respiratory and lower respiratory form. And then you have a disseminated infection, which, remember I talked about granuloma controlling infection in the lung, But in HIV patient and severely immunocompromised, that histone get away from the lung and disseminate through the reticular endothelial system and disseminate through the lymphatic system, go to your liver, to your spleen, to the bone marrow, and then spill to the bloodstream and then go to the skin. So about 20 to 30% of patients have skin lesions. By the time you have skin lesions, it's already very late. Patient already developed very disseminated infection. And in dissemination, we see fever, weight loss, skin lesions, cytopenia, big liver, big spleen, transaminitis, and fungemia. You can see fungemia about 40 to 50% of the time. So how do we make diagnosis? Diagnosis can be by microscopy, and as we talked about, 3 to 5 micron. It looks similar to other pathogen here. Candida globata also look the same size. Talomyces look exactly like histone. And Talomyces looks a little bit different, and we'll talk about it. Talomyces actually divide like a binary fission yeast. So when you look very close, Talomyces has a midline section. It doesn't divide by budding like histone. So that's the single way to differentiate chew. But sometimes you can't see the binary fission. And this is Emergomyces, which is another dimorphic fungi of the second dimorphic fungi of metaphoric form. So you can differentiate by microscopy. However, if you see a patient here in Brazil, that's proven otherwise. Culture takes 2 to 8 weeks, and usually in the old days we do solid culture, take up to 8 weeks. But now with media culture like microlytic egg culture, you can speed up diagnosis to about 3 weeks, sometimes 2 weeks. So that's much faster. Antigen test, we actually have an antigen ELISA from IMI. This worked really well. I'm going to show you data very quickly. It's FDA approved for the urine, but you can actually do that in other clinical specimens as well. In CSF, in fluids, and other fluids, not just in the urine, but the urine performs better than in the blood. Urine has better because the particular protein gets excreted in the urine and filter through glomeruli. You also have Miravista, which you are very familiar with here in Brazil, and that's in polyclonal antibody-based assay. They do have a rapid test in LFA, as you know, that I think has not been approved by EMA or FDA. Okay, so how do we improve our diagnosis? Clearly, antigen test is the way to go, recommended by WHO. Histoantigen test, I know, is not available in Brazil yet, but hopefully soon. It's one of the essential diagnostics that WHO recommend now since 2019. And so it's important that we have histoantigen detection. The thing that we want to do, clearly, histo has very important role in symptomatic patients. But what about asymptomatic patients? This is basically a framework for cryptococcal meningitis. We know that CRIP and CRAG antigen can be detected before patient develop meningitis up to 5 to 234 days before meningitis develops. And so by screening people with histoantigen test, you can put the patient on preemptive therapy and prevent meningitis from happening. This has been proven, the strategy of screen and treat has been proven to reduce mortality by the REN-START trial that was published in the Lancet in 2015. It showed that you can reduce mortality almost by 30% by screening patient asymptomatic and treat patients with fluconazole to reduce mortality. Another trial called Reality Trial that was published in the New England in 2017 showed a mortality reduction as well with the screen and treat strategy. But Reality did a full package of care, including cryptococcal screening, also clotrimazole and azithromycin, and multiple other things, but it's reduced mortality. Now, the WHO did a rapid advice on screen and treat in 2011, and then in 2018, and I sit on this guideline committee, they built a recommendation for advanced HIV disease, a package of care for advanced HIV disease. What does it have? TB, sputum expert, urine lamp for symptomatic patient, symptomatic only, and crack for asymptomatic patient with CD4 count less than 100 and recommended also for 200. These are the only two pathogens that the WHO recommends because we have data for these. And most of these data, as we just talked about, are generated in Africa. And so nothing about histone in Latin America, nothing about chylomicrosis in Southeast Asia. And so it's really important for us to build the evidence base to support a package of care for our region, Latin America, where histoplasma is most prevalent in patients with advanced HIV disease. So in order to build these data, we need to start doing really well prospective clinical study. This is a clinical study we did in Vietnam, and we just finished and about to, we reported at Freud this year and about to write it up. So we basically screened a triple fungal and mycobacterial screening program. This is for inpatient with advanced HIV disease, CD4 less than 100, or WHO stage 3 or 4 disease, regardless of symptoms. They come in the hospital, it doesn't matter whether they have symptoms or not, we screen them. What we did was, so we screened 11,000, we recruited 600 people, because it's a diagnostic study, we exclude people who are already on fungal therapies. You can see a bunch of people, 30-something was excluded because they already been treated for TM, and 40 patients excluded because they were treated for crypto. What we did was, for fungal infection, in addition to conventional method of microscopy, skin, lymph node culture, and aerobic blood culture, we added TM antigen screening that we developed. We added histoantigen screening using the EIA from IMI, and we did crack. In addition, we did microathletic blood culture on everybody. For mycobacteria, in addition to microscopy, ultra expert in sputum and other specimen, and NGIT and LJ culture, we did ultra expert directly in blood of everybody. We did microathletic culture, the same bottle here, and we also added at the end of the study ultra expert directly in the urine, and we gathered that data from Graham Menke's from South Africa. We follow patient up monthly over 6 months. So what did we find? We found huge amount of disease. Chylomicrosis in our region is humongous. 20% of patients, these are culture-conformed disease. Yeah, 20%. Crypto, 5%. And histoplasma, 27 cases, 3%. We didn't even know that histo exists in Vietnam until we did this study. And TB, 28%, this is microbiology conformed TB. And non-TB mycobacterium, 5%. So together, these 5 pathogens made up 55% of opportunistic infection in advanced HIV disease, regardless of symptoms. So we're not basing on symptoms. This is a screening program. So we really wanted to stress that this is a screening study. And as you see, this is mortality, even with screen early and treat. Look at the mortality. For crypto, mortality was 43% with amphotericin. We don't have 5FC in Vietnam. This is a shame because 5FC, I don't know if you have 5FC in Brazil. We do. Okay. So 5FC actually reduced mortality from crypto by 30 to 40%. Very important partner drug with M4B. And so we didn't, and that's why even with M4B, mortality is so high. Look at mortality for histoplasma in yellow, 30%. NTM, 30%. Tuberculosis, 30%. Chylomicrosis, 12%. And this is amazing. This is actually data in real life. In our clinical trial that we did for chylomicrosis, we found that reduced mortality with M4B. But what I wanted to stress is histo mortality is still 30% despite everybody get treated with amphotericin B. So there's a lot of work needs to be done to reduce that mortality. Okay, so Thalomyces, look at gray. Gray color is conventional method that we are having now. The light orange is the intensified method that I talked about, and the dark orange is where these two methods overlap. So look at telomitosis. You pick up 30 more cases, 21% by the intensified method with antigen and fungal microathletic culture. So even that, you pick up 21 more cases. For crypto, the fungal cultures and antigen pick up 45 more cases. Obviously, compared to culture alone, we don't have crypto antigen in Vietnam. That's so crazy. Anyway, so by crypto antigens and fungal culture, we pick up almost half more cases. Histo, none of them was picked up by conventional method, no brainer, right? All these 27 cases were picked up by this intensified method. What about TB? Look at TB. By doing intensified method with ultra export directly in blood, ultra export directly in urine, and microlytic culture, we pick up 56% more cases. This is conventional, and this is intensified approach. Look at all these extra cases you pick up for disseminated disease. So what happened here is TB on these cases, on 85 cases here, is picked up by sputum and lymph node and other things. But these cases, disseminated disease, was not picked up by the conventional method. So by doing gene export in blood and microathletic culture, look at what we pick up. And this is the overlap between microlytic F culture, gene export in blood, and gene export in urine. Surprisingly, they don't overlap as you're supposed to see. I expect they overlap. They don't. And all of these patients had symptoms, and we treat them with TB, they improve. So these are real cases. And again, this you're gonna make a huge difference by doing gene export and microathletic culture, both for TB and fungal disease. And that's what we love to do here in Brazil and Latin America as well. Now, very quickly go through the cohort for histone. So what did we find? These 27 cases of histone, all of them had positive antigen tests. Antigen pick up all those 27 cases. It did pick up, actually the number was updated to 11. So of the 874 cases that did not develop histone over 6 months, 11 had a positive antigen test. So these are called false positive. Right? And when we look at the distribution of OD value, this is called EIA value of the cases in the control, the one didn't develop histone and the one with histone. Look at the difference in the EIA unit, right? So by generating a cutoff of 1.5, you have a sensitivity of 100% and a specificity of 99%. So antigen test in inpatient, in screening is very good. Not just in symptomatic people, but on everybody, inpatient, has a very high sensitivity and specificity. What about positive predictive value? You're familiar with this concept, right? Because, you know, when you have a positive test, there's an 80% probability that the person has histone. That's fantastic. And the prevalence is not very high. The prevalence is only 3% in our setting. Your prevalence is going to be much higher. My suspicion is about 10% of inpatient. And if you have a very high prevalence, your positive predicted value is going to be way higher. And again, this is screening. Huh? This is not just in symptomatic people. It's screening everybody. And so that tells you the test has very good positive predictive value. And look at the negative predictive value, 100%. So if the test is negative, you rule out histone 100% of the time. That's beautiful. This is the clinical utility of an antigen test. And so we need to push forward. This study was done in Vietnam at 3 centers in Vietnam. The disease is here. we need to do this study here to really come up with evidence to tell the WHO we need to screen, and we need to screen everybody, not just symptomatic. So this is what I'm trying to convince you to do this study. What about the laboratory characteristic? There's 27 cases, CD4 counts only 17, very low. And the specimen blood culture was positive in almost half, bone marrow positive in the other 40%, skin lesion in one patient. And the time to positive blood culture is about 3 weeks. Time to positive bone marrow culture is only 2 weeks. So this is microlytic culture. It's much faster actually than the isolated culture system. It's very, very promising. You can pick up histo earlier, and you can do it in bone marrow culture as well. Mortality, as I mentioned, very high, 30%, despite therapy. So very quickly, I wanted to show you the EIA value in different group of patients. So this is culture-proven disease. Look at the EIA around 40. This is probable case, and probable case means they have an antigen test, culture negative, but they have compatible clinical syndrome. And when you treat them with histo, with antifungal therapy, the antigen level go down. So that's our definition for probable histo, without culture confirmed. Look at the level around about above 20, between 20 and 30. And then these are possible cases. These 8 patients have TM co-infection, and they have histo-positive antigen. They have TM co-infection, but in our cohort, we had tons of TM, and 170 cases of TM, but only 8 cases had cross-reactivity with histo. So we think these are co-infection between histo and thalomycin. But the antigen level for histo is very low. And then these are false positive antigen tests. These folks never developed histo. 800 patients, these are 11 false positive. Look at the antigen level is very low. So you can apply the cutoff value to really help you define these people. So perhaps you don't need to treat these people because of the level of antigen is so low. That's what we're trying to find out. What does it look like for Brazil and Latin America? Look at the longitudinal antigen level. So yellows are the culture confirmed. They go down after 24 weeks. So even after 6 months, they're still positive. But you can't tell prognostic between this person and this person. But for this person, you can follow them over time, and the antigen level should go down. So I think there is role to follow antigen level on therapy for that single person. But the absolute value doesn't predict who has severe disease or not. But you can follow the trajectory of a patient. All right, so this blue are the probable cases. These are 4 probable cases. As you can see, antigen is lower, but it's going down. The pink ones are the co-infection with TM. They get treated, and the purple ones are way down here, and they don't change. So I think the antigen level tells you a lot about the burden of histo in the patient. And if you move the cutoff, this is the industry cutoff. EB has a cutoff of 1. But in our study, our cutoff is 1.5, so higher than that. And I think we need to do the study in Brazil, prospective, to really generate this cutoff for our country, for your country. If you move the cutoff to 1.5, even 4.5, what happens is you have less false positive results. 11, 6, and 1. So if you move your cutoff higher, your positive predicted value went from 70 to 81 to 98%. That way, you don't have to overtreat people. Very important to generate this data so that if they're positive, you know that they're not false positive, so you don't overtreat people. This is inpatient. We need to generate the same data for outpatient. So very quickly, this is data ongoing. This is an outpatient cohort, asymptomatic, outpatient with low CD4 count, and we did the same thing. And what we found was that 3.3% of thalomycin, histo's only 2 cases, more crypto, more TB. But you can see thalomycin and histo are much less common real disease, not antigen positive. This is real culture positive disease. And it's much more common in the inpatient cohort than the outpatient cohort. So clearly, histo happened really in low CD4 count, in symptomatic people, sick people, not outpatients so much, but there are some. And when we look at these two people, they actually were symptomatic. They're not asymptomatic people. These two cases developed histo. Again, we need to generate data for outpatient, and the whole idea is that we can generate such data for Brazil, for Latin America, for Southeast Asia, beyond Vietnam, so that we can then provide very good evidence to support a package of screen and treat appropriate for our region. So we're talking about screening for TM, histo, crypto, and screening for TB with a gene export directly in blood, TB lamp, etc. So that's what we're trying to generate, the evidence to support. Do I have 2 more minutes? Okay, 2 more minutes. Just talk about treatment strategy. So you know that for histo, liposomal F will be better, less toxicity and actually better efficacy compared to the oxycolate. You know that, right? And the question is can we do better than that? Than liposomal F4B for 14 days. So the goal of any antifungal therapy is to improve efficacy and reduce toxicity. And this study, so is F4B does less equal more, essentially. Is single dose F4B is good as 2 weeks of F4 So this study that Professor Falci already just presented, the Ambition trial was published in New England, show you that single dose reduced mortality from 28 to 24. So actually 5% absolute reduction in mortality. And why? We think that by reducing, by single dose, you actually reduce the complication from F4. Even liposomal FB, you have complication. It's just less, but it's still complication. So reduce mortality and also less side effect. We also see very clearly, even with single dose liposomal F4B, the clearance of the Cryptococcus yeast in the CSF is exactly the same. Look at this, 0.4 log CFU per mil per day, 0.42, exactly the same, right? So this is very telling that single dose work good, and the side effect overall, 50% for liposomal F4B single dose, 50%, so a 30% reduction in side effect. And so you did it here in Brazil. Professor Pasqualotto and Falci did this study, and you published already. And when I presented this earlier, it wasn't published yet. It's already published in CID, and so you know that this trial was done in multiple centers in Brazil, and I think 118 people was randomized in 6 centers in Brazil. And there's 3 single dose liposomal F4B. Arm 2 is single dose day 1 and give half of the dose day 3, and the last half is liposomal F4B for 2 weeks. And so you saw pretty much the same. Mortalities are very similar between the 3 groups, and interestingly, you see a lot of mortality happen in the first few weeks of therapy. After that, everything leveled off, and it's still 25% mortality, so very significant mortality, even with single dose liposomal F4B. So that tells you that there's more work needs to be done. And I believe you also find less side effect, kidney function, less side effect. So you are running a multi-center study, phase 3, so we're very excited, looking forward to that study result, but we expect it to be very good. So that will provide evidence. So take home message for diagnosis. I think antigen detection is absolutely crucial for symptomatic patients. It has excellent performance, excellent positive predictive value, but also for screening. So we need to push. We don't have any evidence for screening of asymptomatic people and treat asymptomatic people. But I think for our study in Vietnam that I hope I convince you that even in inpatient, you can screen and treat. And the performance of antigen test, histoantigen test, is fantastic. I think you need to develop assay to detect late infection, like interferon gamma assay. I know there's an antibody assay. In fact, I don't know how well that works. But interferon gamma assay, for example, like a quantiferon for TB, is really needed because you need to know how many patients, how many people in the population in Latin America have been exposed to this stuff. That is important for epidemiology study. You need to know the denominator of their population has been exposed, and you need to know who have been exposed, who's going to need to undergo impending chemotherapy, right? TNF alpha therapy, immunosuppressive therapy. If they have been exposed and have late infection, do you need to treat them preemptively for histo? That needs to be done, and you need a diagnostic for that. So I think there needs to be assay so that you can expand your understanding of not just disseminated end-stage disease with positive antigen. That's where we are now. But we need to understand the spectrum of disease beyond that disseminated state. We need an assay that complements antigen, host-based assay, diagnostic. Interferon gamma also gives you a level of interferon gamma release, and perhaps the level tells you different stages of infection as well. So there's a lot to be done. Treatment, as I mentioned, liposomal M4B has better efficacy. That was done more than 10 years ago. Single dose is as effective and less side effects based on your phase 2 study, and we're looking forward to phase 3. But is there a role for improvement of treatment? Yes. I think 30% is unacceptable with liposomal M4B. Look at what we've done for talomyces. We reduced mortality from 30% down to 12 to 13% with M4B, and we are doing another clinical trial combining M4B and 5-FZ because we found in vitro evidence of synergy between those two drugs, similar to crypto. So the idea of combination therapy is very probable for this stuff because there's now different antifungal drugs available. There's phosphanatropates, there are olorofin drugs, there are ibrexafungal that work on the fungal cell wall. So perhaps in addition to fungal membrane like liposomal M4B, adding a fungal cell wall agent will have synergistic effect. And I really hope that we're going to continue to build networks so that we can do clinical trials to improve treatment of patients with histoplasmosis. Prevention, I think we need to screen and treat, both in hospitalized and outpatient, and we are going to write a grant application together to build evidence to support that strategy. And then when to stop secondary prophylaxis. Right now, we keep itraconazole for about 12 months, even longer, until CD4 counts rise above 100 for 6 months or so, right? That's a long time. Do you need to keep that for that long? Probably not. So based on PCP data, my hypothesis is that you probably can stop when the patient develops biologically suppressed. After you treat for 6 months, at least 6 months, and after 6 months, your data has shown that right here, your data have shown that after 6 months, everybody did well. So you don't really need to continue therapy, particularly if the patient is on anti-retroviral therapy and biologically suppressed. So I think we need to do a study to cut short the duration of maintenance therapy to just 6 months if the patient is biologically suppressed without antifungal. That's going to reduce the need for antifungal, reduce toxicity, drug-drug interaction, and cost, and drug resistance, right? So there's many benefits to cut short secondary prophylaxis or maintenance therapy. That's another trial waiting to be done. So I invite all of young people to join histo. There's a lot to be done, both in diagnostic, treatment, and prevention. So that's it. This is a network that I have built for talomycosis, but also histoplasmosis research. We have multiple sites in southern China, in Vietnam, in Thailand, and so these 3 countries are going to form core network in Southeast Asia to advance diagnosis and treatment of talomycosis and histoplasmosis. And finally, this is my team at Duke, very young, energetic, we do a lot of preclinical development of diagnostic and preclinical testing of drug. And this is our team in Vietnam, our research funder, and our network of hospitals. So thank you very much for your attention.
Thank you, Thuy. Fantastic talk. I would like to invite Diego and Thuy, please, to sit there. Yeah. And we are open for questions, please, from the audience. And for those who are watching us at home, please send your questions by write, and we said we can help us to send them to the speakers here. Just gonna pass this. Questions, please. Pode perguntar em português se quiser, tá? Eu passo para inglês. Fique à vontade. Importante a interação. Thuy, what do you think? Sorry? Good question there, sorry. Tell me before?
No. We know that.
No, we can't hear you.
We can send.
Good, thank you. Or we can do differently.
Oh, there you go.
Melhor, né?
Português ou inglês?
Não,
Pergunta em português ou inglês?
pode ser.
A gente sabe que o risco das vozes, por exemplo, né, tem um grupo de risco é a imunossupressão, né? Mas a gente tem visto alguns trabalhos que mostrado que o Covid longo, né, long COVID, tem de alguma forma diminuído também um pouco isso, tem alterado a relação com o modelamento pulmonar. A gente tem algum dado em relação a isso em pacientes que já foram expostos a Covid longa ou que tiveram algum tipo de Covid qualquer no tratamento deles? Sim, agora pelo tipo de
Yeah, I don't think there's much going on with the endemics and COVID. Clearly, there's aspergillus problem, mucormycosis problem, some PCP issue, but we haven't seen endemic, even in Vietnam, where there's lots of telemycosis. We didn't see a lot of telemycosis with COVID-19 for some reason. And I don't know why, but we don't. Thanks for the question.
I think we published a case report only about history after COVID with this Xavier from Ukraine, but it wasn't really a big issue, history after COVID. Thuy, could you please comment on the interferon gamma release assay for history? QMR has published a paper on that. I was interested if we could use that in the study we are doing to evaluate duration of treatment. We think that's really useful to determine how much treatment patients need.
Yeah. So yes, Professor Kiermar developed a quantiferon assay for histone. It's not commercially available. It's only in a research setting. It's basically looking at the host immune response. And so I don't think they have done a study in different population. They only have I think like 20-something case of histone, non-histone case, very small study. And it's all done in acute histone. So they haven't really done longitudinal follow-up and see what happens to interferon gamma level on treatment. You know, whether the host respond to histone reduced, you know, whether it's reduced on treatment. So that work hasn't been done yet. So we don't know. But in TB, we don't use quantiferon for follow-up of patients. And so there's no data that quantiferon is actually able to differentiate, you know, treatment versus not. But there's some evidence to support severe disease versus non-severe disease, quantiferon gamma for TB.
about the interferon gamma S for history. We have data on patients because when we talk about serology has reduced sensitivity for the case of immunocompromised patients, so it's not feasible for HIV patients, for instance.
So Mike, that's a great question. So in HIV patients with profound immunosuppression, particularly T cell function, they have T cell exhaustion, and so the interferon gamma release from T cell is going to be suppressed, and that's absolutely true. I think that in HIV patients with histo, quantiferon is not going to be used to diagnose acute histo. It's more for, do people have latent histo? So I think the test will be more useful for studying healthy people. Like I mentioned, how many people in the general population have been exposed to histo and have latent infection? I think that's where it comes in. And then a person who is going to be undergoing impending immunosuppressed therapy, whether they need to be preemptively treated. But I don't think it's going to have utility in diagnosing acute. So, and I agree with you that advanced HIV disease will have very diminished T cell response. It may not have, but we don't know. We have to do the study.
I'm trying to remind myself of your slides on the comparison of different diagnostic tests for histo. But do you see an advantage of having micro-F blood culture for histo, for those centers who have access to for histo particularly, not for TB or you see an advantage of having micro-F?
Yes. So for histo particularly, the advantage of micro-F, I would say, all of the people who develop histo have a positive antigen test. So antigen pick up everybody. So the sensitivity was 100%. The advantage is really that, by the time you grow it, it's already 3 weeks later, right? Whereas antigen, you pick it up early. So there's really no advantage except for, I would say, in the study we've done is in advanced HIV, so you see disseminated infection, right? This will show up in blood. But I would say in other patient, transplant patient with cancer, a particular area, the advantage of micro-F lytic culture for particular specimen like pleural fluid, bone marrow aspiration, lymph node aspiration of any clinical specimen, growing a microarray, will have advantage because the antigen will be negative. So I would say in those patients, it's going to have advantage.
You probably know, but so nowadays we have access in Brazil to leproscopic after for histo. It's something risky in the country, but histo antigen is not available. So we pay for Amazon, but we don't pay for diagnostics. Yeah. So in the end, we diagnose, we treat patients in the very late stages of disease, more success very high.
That's a shame, and I hope very soon. I hope very soon you're going to have histoantigen. I think the issue with histoantigen is not just Brazil fall. I think that the MiraVista test that you have access to, the LFA, is not commercialized very well. Even in the US, we don't have an LFA at Duke, right? So if I want to get a histo test done, I send it to Joe Weed. I hope Dr. Joe Weed is not listening. I send it to Dr. Joe Weed lab, and he does it for everybody. It's still in his lab. So it's not even available commercially in the United States. Why? He never got it FDA approved, right? So I know Joe Weed gonna hate me if he listens to this, but he hasn't gotten an FDA approved. Therefore, it's not commercially available. It got sent in a research setting. That's why you have access to it. Right? The EP ELISA test is commercially available and FDA approved. So that one we should use for our study. because it gives you a quantitative level. As I hope I convince you the quantitative level is important for prediction of who's going to have disease, real disease or not real disease. Particularly, this is going to be more important in asymptomatic folks, outpatient. Lots of them are going to have low level, and they may not develop disease based on our experience. In cohort 2, I haven't shown you the data because there's not time, but 2 people who developed disease on the outpatient cohort are symptomatic. And then we had 11 people who were antigen positive but never developed disease, and the EIA level was very low. It was positive, above 1, but it's like 1 to 5. So if you set up a cutoff of 5, you can eliminate all of them. And I think that we're going to push for that in our setting, that in outpatient, the cutoff of positivity should be above 5, not above 1. And all of that data needs to be done here to generate. So you need to generate that data to inform policy. Right now, the company just say 1 is positive. And that's dangerous because you then pick up a lot of positivity in different settings. You have to study inpatient, symptomatic, asymptomatic, outpatient. All of those populations are different because the pre-test probability is different. Therefore, the test performance will be very different. Your pre-test probability or the prevalence of the disease will dictate your prognostic performance, your positive predictive value, negative predictive value. So I hope I answer your questions.
I have another question that I found it interesting to discuss it here. It is a good clinical question. I'd like to hear both your opinions. It's about the definition of severity of the disease. Because the WHO definition is somewhat vague. So you don't know really what is mild, what is moderate, what is severe. Because it's important to give the right treatment of the patient. It will probably influence the outcome. So what would be the minimal clinical workup to the definition of severe disease? What would you like to have a CT scan or labs? How could you definitely have a precise definition, categorization of disease, of history?
So I think for disseminated disease, there's obviously always a spectrum of disease, mild, moderate, severe, sick, based on when the patient come in, when you catch the disease, when you make diagnosis. Some people come in early, some people come in very late. So it's basically about the timing that you are diagnosing them. The only way to know the prognostic of the disease is actually to do modeling. Actually get a bunch of variables that you think predict mortality. Let's say you bunch of things you predict mortality, and then you're going to model it, and then you actually do multivariate analysis, and you assign different based on the coefficient of prediction of mortality. You assign a score, and then you can have a score algorithm. Like severe mean a score of this, moderate mean score of this, and mild score of this, and whether that predicts severe disease. In order to do that, we need to have a very nice, in your trial, you probably can do that, because you have so you just define a variable that you think will predict mortality, AST, ALT, hemoglobin, platelets, CD4 count, age, sex, injection drug use, all of those, and then you build a model based on the coefficient of prediction, or the odds ratio of prediction of dead or alive by the end of 6 months. Are you following up for 6 months for your trial?
For phase 3, 10 weeks.
10 weeks. So 10 weeks, okay. Then you build your model, and then you can work out the score, and then validate it too. You need to validate your score with another study.
In the phase 3, we will be using the variables that Antoine from French Guiana tested always. This was most score, that's score. Priscilla, I think she wants to make a comment on this.
First, I have a question. I'd like to first thank both of you for the great lecture and the privilege to be here. I have a question regarding the guidelines for treatment of neurocritical pulses. Why do you think that some guidelines recommend single dose for for low-income settings and 14 days for high-income settings, because you could think about severity. Perhaps patients in low and middle-income settings, they present with more severe disease due to delay in diagnosis and higher incidence of advanced AIDS. So why do you think there is a difference in that?
Well, I think I may have explored some of the arguments, but actually it's a difference of context. So the authors that question the official results extrapolation to the high-income countries, they argue that the context of the disease in the high-income countries is very different from the low-income countries. So we have other arguments on the contrary, but mainly is the difference in context and the drug availability, because we still have countries that do not have access to liposomal after surgery, and they cannot implement the ambition trial strategy. So they still use the previously recommended WHO regimen, which is unforeseen the Oxford. So I think there is a wide difference in context, and this applies to the different recommendations in the guidelines.
I was at the MSG meeting in Colorado, and I asked the same question. So why in America you have this discussion? Because the data to me is pretty solid that a single high dose is as good as, it's much cheaper, much less manipulation of intravenous access, etc. They didn't really give me a clear answer. They said, well, the patient will have to be in the hospital anyway for to monitor intracranial, increase intracranial pressure, but this is a different thing. We need lumbar puncture, but why do we need to keep the patient on Amazon for longer? I don't see the reason. And to me, it's even more difficult to understand why in Brazil they're still not using that. Maybe because we are a rich country and we can spend money easily on anti-fungal. Well, how do you see that living in the US? Why the debate?
Yeah, so I can add to that. So John Perfect, you know him, right? John Perfect. I hope he's not listening. John Perfect is my boss, who recruited me to do. He's the founder. He's basically really famous person on cryptocurrency who write all the guidelines he developed the world. So this is a conversation he and I had. Right? Basically, the study wasn't done in developed world setting. The study was done in multiple countries in Africa. And his argument, the argument on the other side, that maybe in developing country in Africa, the monitoring of patients are not great. For example, magnesium test is not available. It's very difficult to monitor magnesium. It requires very sophisticated testing. So potassium, magnesium is not very well monitoring, and that's why a lot of patients die because of poor monitoring. That's why mortality is so high in Africa and Asia. Mortality for crypto is about 30%. In the US, based on a study done 20 years ago, mortality is 10%. So they go, oh, low mortality, maybe it doesn't work. It doesn't make any sense because, like Alessandro and I said, basically the data is very convincing. Even in severe case in Africa, you could see the rate of fungal clearance, as I showed. So if single patient wonder work and reduce the rate of fungal clearance the same way, there's no reason why it won't do it in milder patients. It would be better in milder. Even in people who had better monitoring, it should be better. So the argument didn't work. However, a lot of things happen is that if the trial is not done in that setting, it's difficult to extrapolate. And that's the only rationale. It wasn't done in Western country, but there's never going to be a trial of crypto done in America or Europe. They don't even have the patient. So there's never going to be a study, unfortunately. And so I think it's a shame that a guideline have rich country and poor country. It's just ridiculous. So I agree with you. Even my boss and I disagree.
Thank you very much. And just to comment on what you were saying about, I think Diego described it very well, that the guidelines for histo, the definitions are very vague regarding light cases, moderate, and severe cases. And like Professor Pasqualotto said, we are going to do a predictive score within the induction trial. However, do you think that perhaps we should include mild cases that perhaps are not contemplated in the trial because they won't be hospitalized?
But these patients don't need Anderson.
Yeah, but to have a score that adequately discriminates between mild and moderate, you need the mild cases. So probably it will be for predictive of mortality, but not for the choose of the treatment strategy.
I think one of the key things is when do we need to put this patient on itraconazole or when do they need Anderson? I think there's no clear difference between groups. This is something that has to be evaluated further.
I can tell you from the event trial that we published in the New England Journal of Palestrastantes, we look at heterogeneity between different patients, different severity of disease. So you do a forest plot and you look at patient mild versus moderate versus severe. All of them. I don't have the data here, but I'll share with you. There's no difference in the benefit of MPB compared to itraconazole across the board. So everybody did better with MPB regardless of disease severity, even mild, moderate, based on some clinical judgment. For example, people who need oxygen, people who don't need oxygen, people with lower CD4 count, higher CD4 count, injection drug use. So a few things that we consider severe versus non-severe, benefit is the same. And so when I wrote the guideline for thalomycosis, I said MPB should be induction therapy regardless of disease severity if the patient had disseminated disease. But you're absolutely right. If people don't come in the hospital, you don't even know. You don't know. You will never know that population. So of those who come into you, at least for thalomycin, MPB is better across the board, whether mild or moderate, based on the clinician judgment. So that tells me he's still probably the same way. And so I think, yes, you could do the academic exercise of, risk score, but if I have histoplasmosis disseminated disease, give me amphotericin B. Don't give me itraconazole. Why? Itraconazole is fungistatic. It inhibits aldosterone synthesis, precursor to aldosterone. What MPO does, essentially, like a magnet, it sucks out aldosterone from the membrane, causing destabilization of the membrane and cell death. So it works much more. MPOB is not an antifungal drug, but it's more potent than amphotericin B. It's toxic, that's a problem. So there's a new drug coming out called Fungal, developed by a company, biochemist famous. They actually doing phase 1 now of a drug that doesn't cause side effects because it's target fungal cytochrome. Fungal aldosterone and not human aldosterone, human cholesterol. Aldosterone looks just like cholesterol in human. That's why you have toxicity. This particular MPB only target fungal aldosterone, not cholesterol, so no side effect. It's in phase 1 trial. It's an MPB designed to target fungal, not human. So in the future, you're going to have much more tolerable drugs.
Okay. First of all, thanks for the presentation. I'm a little nervous, so if I will try to say it in English, but okay. Are you guys trying to search more about any other drug to treat crypto or the other one? Sorry, I missed yours. I just wanted to know about it.
You mean research new antifungal drugs? Yeah, we're not smart enough to do that. No, there's a lot of people working on it, but pharmaceutical company, research and development are working on it, and we have 3 new in-class antifungal drugs in clinical trial right now that work in different mechanisms, a different life cycle of fungus. So it's very exciting time to study mycology because you've got new drugs, oral drugs. All of these new drugs, like Brexafungum, Olorothin, fosmanogenics, have IV and oral form. So, and they work differently. So there's some fun stuff. Oteseconazole is another drug as well. It's a 4th-generation azole that get metabolized to fungal cytochrome and not human cytochrome. So no drug-drug interaction. There's 4 different drugs out there, oral, that we can test, can play around with, and can add to amphotericin B for histone. I think there's a lot to do because we got new drugs. But yeah, people are looking. There's a lot of basic research trying to understand, new mechanisms of actions and come up with stuff all the time. Not us.
I have a question for Diego and Thuy about the natural history of histoplasmosis. What is your feeling? Do patients get a new exposure to histo when they get infected, or is it reactivation of previous infection in terms of data that is available? And the second question is, do you believe that those who have very mild or no symptoms at all, and they have positive antigen, do they benefit from antifungal therapy, or is antiviral therapy enough to clear histo?
Well, my feeling, and we do not have data to answer these questions, but my feeling is that about the new exposure or reactivation, I think it depends on the host. Maybe HIV-infected patients can reactivate disease, but probably disease in other hosts, such as users of TNF blockers, they need to be exposed to develop the disease. And the other question about the preemptive therapy, well, I think maybe we can identify the cutoff that probably will classify patients that could benefit from preemptive therapy and other patients that could only use antiretroviral therapy and therefore do not use antifungal medicine. But well, we do not have the data to adequately answer. As I said, we look forward to get it in the next study.
I think we do need to generate these sort of prospective natural history data, not treat yet in these asymptomatic folks with antigen and follow them closely and look at their antigen level over time. And if they develop first signs of symptoms, you treat. So I think we need these natural history studies to be able to inform guidelines. Otherwise, we keep talking about this without any data to inform us.
What do you predict? What do you expect?
So I predict that you can predict who's going to go on to develop disease that needs to be treated based on what we collect routinely in clinical judgment, like the hemoglobin, the platelet, the AST, AOT level, the antigen level. So I think collectively we can then model that and predict that based on available clinical data from our patients to predict whether you need to treat or not. And we need more data for that. We need a prospective study. The other thing I wanted to ask about acute versus reactivation disease, I don't know about histone. Talomyces, there's a seasonality. So about 30 to 50% increase of cases during the rainy month. And so that tells us that there's a more Talomyces in the environment in the rainy season, right? That people are exposed to. So that tells us that there's an acute form, acute primary infection, and also there's a reactivation disease. We know reactivation disease happens in patients with advanced HIV disease. And we suspect that people who have low CD4 count, susceptible, come in contact with histone, develop acute disease, acute pulmonary infection, they're probably more severe than the people who reactivate from their own, they've already have it, and slowly take time to develop reactivation. And we see in the IVAC cohort that people with pulmonary symptoms, they come in with cough, shortness of breath, the duration of symptoms are much shorter, within 7 days. Whereas the people who have long duration of symptoms, the mortality of people coming with long duration of symptoms actually are better. The people who come in with acute illness that involve pulmonary, they did worse. They progressed to mortality faster. So we think that the people who had primary infection are more severe disease because their immune system haven't seen this and they get overwhelmed.
Do you think previous exposure protect patients from getting
severe disease? Because I think, when they reactivate, the body's already somewhat familiar with this antigen. They've already been exposed, so they have memory T cell already rep up, even though it's impaired. But the way that they, just like hepatitis B, the way that they reactivate, they're going to say, okay, you're there, I just can't get rid of you. But in acute, it's just like, oh my God, it's like COVID.
There has to be to finish, but I have one more question. Is how do you use histoantigen to follow up patients on treatments? You've shown that the histoantigen titers they decrease very slowly over time. So how do you use them to say patient is responding, patient is doing well, now it's time to stop?
I don't have that. We are not, we haven't incorporated the clinical practice. We know that antigen can be used to follow up the patients. We saw this in our studies.
So I would say that you can use them to make sure that they're going down. Look at the trajectory, everything going down. So if a person stop ARV or stop antifungal, it's going to go up. Joe Weed have shown that. So you can use it to monitor that particular person. The antigen level may not be prognostic for treatment effect. It may not tell you that N4B is better than itraconazole, it's better than that based on the absolute value. But if you follow the trajectory over time, it's going to help. So I think it's up in that sense. And I think it may help with decide when to stop itraconazole maintenance therapy. If you follow them and do when to stop, maybe the antigen will tell you the resolve. So we need to do that step.
Any final burning question from the audience? Because we were supposed to close by 9. I think we have 2 minutes. 9. Any final comments from you?
No final comments. Thank you. Thank you. Thank you for the audience. It's an historical event.
Thank you very much for your attention and being here late at night. Thank you very much.
Thanks a lot. Thanks to Diego and fantastic night. Thanks very much. And thanks, Dr. Brishet, for organizing all the transmission online. Thanks for you guys at home. Enjoy the evening. Bye.